Chapter 20 is about traction, and we are going to talk about mechanical and manual traction, and we're going to practice it in the lab. And you'll get time to work on traction in the third lab and in the fourth lab. So in November and in December. And both labs, Pierce and Whatcom, have traction table setups, and you'll practice manual traction as well. Well, it'll be fun. So the learning objectives for this section, I want you to be able to summarize the main effects of spinal traction for joint distraction, reduction of disc protrusion, soft tissue stretching, muscle relaxation, and joint mobilization. Discuss the different types of traction and when they might be the best application. General contraindications and precautions as per usual. Parameter selection for mechanical traction based on clinical indications. And there are some really good tables in the book that cover this, and they're great references. And in the lab manual, there's also some reference tables. Discuss how the angle of pull influences the location of pull on the spine for cervical and lumbar traction. So if you're more flexed, is it upper, or does it focus on the upper or lower cervical spine if you're more extended, or if you're in a neutral position? The integration of traction with other modalities. So other modalities that we talk about in this class, might they be helpful before, during, or after traction? We'll talk about it. So spinal traction, mechanical or manual, can be used for joint distraction, can help to reduce disc protrusion. It can help with soft tissue stretching, muscle relaxation, and joint mobilization. For joint distraction, the traction separates two articular surfaces perpendicular to the plane of articulation. So it reduces joint compression and widens intervertebral foramina. So if you have foraminal stenosis, traction can help relieve pain sometimes because it widens that intervertebral foramen. May reduce pressure on articular surfaces, interarticular structures, or spinal nerve roots. So people that have facet joint compression, facet joint problems, traction may be helpful for them. It requires enough force to distract the joint. So ordinarily 50% of body weight for lumbar joints and 7% of body weight for cervical joints. So a lot of times you do have to calculate these numbers. And it's not that hard to do. Some of the newer traction units, like they're the ones that are in the lab, they calculate it for you. You enter in the body weight and you enter in the percentage that you want, and it calculates it for you. But you might run across in the clinic, you might run across one that doesn't, and that's okay because you can do it yourself. To reduce disc protrusion, it requires sufficient force in the lumbar spine. You want 60 to 120 pounds, or 30-60% of body weight. And these numbers are also in the tables. I do want you to know these numbers. Cervical spine, 15 to 30 pounds. The soft tissue effects, soft tissue stretching and muscle relaxation. Soft tissue stretching may contribute to spinal joint distraction as well, and reduction of disc protrusion, or just an increase in spinal range of motion just because you're stretching the soft tissues. Muscle relaxation can be due to reduced pressure on pain-sensitive structures or gating with intermittent traction. So with intermittent traction, you're doing it with a mechanical traction unit, or you could do it manually, but you're on for a certain amount of time, you're off for a certain amount of time. And so just that stimulation to the pressure receptors, the A betas, you can get a gating effect, and that can contribute to pain reduction and muscle relaxation. For joint mobilization, usually it's done by high force traction, meaning more than 50% of your body weight, or repetitive intermittent traction, and it mobilizes multiple joints at once. As you know, there are lots of different joints in your spine. There are the intervertebral joints, there are the facet joints, and there's a whole bunch of them. So when you use traction, it mobilizes many joints at once. Manual techniques can be more localized. You can do individual segmental mobilization for individual spinal joints. So, clinical indications for traction: spinal disc bulge or herniation, spinal nerve root impingement, joint hypomobility, subacute joint inflammation, or muscle spasm. If you have a disc bulge or herniation, lumbar traction may decrease the size of the herniated disc material. It reduces compression on the spinal nerves if you do that. Lack of significant clinical benefit from traction may be related to severity or the location of the disc protrusion. So some locations respond better to traction than others. So, cervical spine, usually you don't get the huge protrusions like you do in the lumbar spine, and so you tend to get more positive outcomes in the cervical spine. It's really interesting to look at the research that's out there for traction. A lot of it is pretty old. There is a little bit of newer stuff, but um, not all that much. And so traction's one of those things that if the patient seems like if you think it might be indicated for that patient, sometimes you try it and it works, and sometimes you try it and it doesn't work. So if it doesn't work, then don't do it again. Try it, and that might not be the treatment for them. Or maybe try some manual traction. If they respond positively, mechanical traction might be useful for them, or a home unit. And we'll look at some pictures of home units, and we have those in the lab as well. So nerve root impingement associated with disc bulge, ligament encroachment, foraminal stenosis, osteophytes, nerve root swelling, or spondylolisthesis can be helped by mechanical or manual traction. It's best applied shortly after the onset of symptoms. In patients who get worse symptoms with spinal loading and decreased symptoms with decreased spinal loading, they usually respond well to traction, and that kind of makes sense, right? Traction sort of unloading the joints a little bit. For joint hypomobility, traction can glide and distract spinal facet joints to increase mobility. The effect is non-specific because it affects multiple joints, but distracting those multiple joints can help increase mobility in the ones that are hypomobile and all the other ones too. Increased flexion localizes the force to upper and lower thoracic. Neutral or extension localizes the force to lower lumbar. So if you have joint hypermobility in the lower lumbar area, you want to do traction in neutral or in lumbar extension. If you so that the angle that you do it at is going to change. If you want to do the upper and lower thoracic, you want more flexion. So I've got to say, I probably have more of a tendency to use manual segmental mobilization than to use traction for joint hypomobility. But I'm sort of hands-on manual type person. So and the PTs that I work with, same thing. So it's an option, we'll just say. Subacute joint inflammation, the traction force reduces pressure on the inflamed joint surfaces. So if you have joint inflammation in your facet joints because you have arthritis, if you do intermittent traction, the small movements may gate pain and help maintain normal fluid exchange in the joints. That can be helpful. Muscle spasm, static traction, or low load intermittent traction may interrupt the spasm pain cycle. Higher load traction may reduce the underlying cause of the pain. So again, you try it with someone, and if it's helpful, then yay, you might do it another couple times. If it's not helpful, then maybe you need to do something else. Contraindications: if you don't want to increase motion for whatever reason, like you have a fracture or something like that, you don't want to do traction. If you have a acute injury or a lot of inflammation, so the subacute inflammation that we talked about earlier, that's okay. But if you have an acute injury, traction is probably not your first choice. Joint hypermobility or instability, yeah, you don't want to make it more mobile and less stable. Peripheralization of symptoms of traction. So what we want, if somebody has nerve impingement, a lot of times they have the pain goes down their leg, peripheralization of symptoms, and you do the traction and you get centralization of symptoms. That's what we want. If the peripheralization gets worse, then don't do it. The traction's making it worse. Uncontrolled hypertension, because we don't want to put any more pressure on someone. And some of it is the just the belts putting pressure on them. For precautions, structural disease conditions affecting the spine, like sometimes like scoliosis or ankylosing spondylitis, that those sort of things, structural diseases that affect the spine. When the belt pressure might be hazardous, like when somebody's pregnant, it might not be the best time to do mechanical traction. You could probably do manual traction if somebody who's pregnant. A displaced annular fragment, because we don't know where it's going to go when we do traction. Medial disc protrusion is a lot of times not helped with traction, and it's kind of one of the less common things. Um, when severe pain fully resolves with traction, that's a kind of a red flag. We're like, something's going on. And we probably want to be careful with that. Um, claustrophobia, sometimes if people are claustrophobic, being strapped into belts and attached to a machine is just not comfortable for them. So manual traction might be an option for a person who's claustrophobic if you really want to do traction. Inability to tolerate prone or supine position. So if they can't get in the position you want to do traction in, that will make it very hard to do it. If they're disoriented for cervical traction, if they have TMJ problems, cervical traction could aggravate it, or dentures. It can, have you could have fit issues with the dentures. So for cervical traction, you just want to watch jaw stuff. So traction on lateral versus medial disc protrusion. Nerve root compression by lateral disc protrusion is generally relieved by traction. Nerve root compression by medial disc protrusion is a lot of times aggravated by traction. That's why medial disc protrusion is a precaution. You don't want to aggravate somebody's pain. Potential adverse effects. Excessive force with traction may increase the person's symptoms. That's not good. We don't want to increase people's symptoms. You might have a rebound increase in pain. So when you first start traction, you're going to start low and increase slowly. Lumbar radicular discomfort after cervical traction. So if you do cervical traction and then you have it, radicular lumbar discomfort, that is a potential adverse effect because you're pulling on the whole spine, and all of the whole spinal cord, all of the descending tracts go through the cervical area, so it can cause problems in the lumbar area. So in general, obviously evaluate the patient and determine the appropriateness and safety. Select the appropriate form of traction. Are you going to do static or intermittent? Are you going to do manual or mechanical? You're going to explain the procedure to the patient. You're going to apply the traction. When the treatment is complete, you assess the outcome and you document. If someone has severe pain and you put them on mechanical traction and their pain immediately goes away, gradually decrease the pressure and take them off the traction because something else is going on. So mechanical traction, there are various kinds of belts and halters and positions and devices, continuous versus intermittent. When you look at the charts in the book, and we'll do this in lab, it'll recommend when you start with continuous, when you start with intermittent. So you'll see in some of the photographs, like this one, for lumbar traction, if you want someone in flexion or extension, you're going to put them in different positions. A lot of times, if you want to do traction and extension, you have them prone. Traction and flexion, you have them supine with their legs elevated. For cervical, you can vary the angle with the halter that you use. So depending on where you want to focus the traction in the cervical spine. Cervical traction can often be helpful for cervicogenic headaches. Recommended parameters for lumbar spinal traction. Your initial treatment, you're usually going to do, or if the person's acute, you're usually going to do static traction for just 5 to 10 minutes, 13 to 20 kilograms of pressure. So about 30 to 40 pounds of pressure. And so just that initial thing, you do a short session, see how they respond to it. Then if you're doing it for joint distraction, you want up to 50% of their body weight. Intermittent 15-second hold, 15-second relax, 20 to 30 minutes. To decrease muscle spasm, shorter on-off times, 5-second, 5-second, with 25% of the body weight for 20 to 30 minutes. For disc problems or to stretch soft tissue, 25% of the body weight, 60 minutes on, or sorry, 60 seconds on, 20 seconds off for 20 to 30 minutes. So the first treatment you do static for a short time, and then the second, if they respond well to that, then the second treatment you're going to do, depending on what you're trying to treat, what the indication is, you're going to do different amount of pull and different on-off times. Okay. If you're using a home unit like is shown here, this is a lumbar home unit. You can do intermittent just by timing it, and the patient is controlling the pressure. So if the patient is getting a home unit and you're teaching them how to use it, you can show them how they can control the pressure, and I let them hold it. In the mechanical systems, there's a stop switch that you give the patient so they always have control. One person I used to work with, she called it the chicken switch, which I thought was kind of funny. But they can always stop it and the pressure will go off. For cervical traction, again, you do static for your initial at a pretty low pressure. For joint distraction, you want to go about 7% of body weight, 15 on, 15 off. So the on-off times are the same as for lumbar, just different amount of pressure. And of course, the cervical vertebrae are much smaller than the lumbar, and you use less pressure, less pull. So the advantages of mechanical spinal traction: force and time are readily controlled, graded, and replicable. So it's really easy to set it up so it's automatically doing the timing. It doesn't require continuous supervision, so you can have someone on traction. You can give them the chicken switch or whatever you want to call it, the safety switch, and and go and do something else, go and see another patient or whatever. There are some static weighted devices that are inexpensive and they say convenient for home use, but some of them are such weird setups. I don't know how people would do them at home. But there are other ways to do traction at home, and we'll look at them really quick. Disadvantages of mechanical traction is the devices are expensive, so it's not like one you're going to be buying at home. The setup is sort of time consuming, and you do need another person to set it up. You wouldn't ever do it at home because you need someone else to set it up. The patient, it's pretty passive on the patient. The only control they have is that safety switch, and they're not really participating. They're just laying there while the machine stretches them. Um, they feel restricted by the belts or halters. That can be a disadvantage. And it mobilizes broad regions of the spine. So if you want just segmental mobilization, you're not going to get it from mechanical traction. So you can also do traction for hip, for pain relief, in about 20 to 30 degrees of hip flexion, and 15 to 30 degrees of hip abduction and maximal external rotation, just to mobilize that hip. You can also do manual hip mobilization, which is probably more common. To increase range of motion in the hip, extension as tolerated, abduction as tolerated, and maximum internal rotation. So hip traction is something that is sometimes used, and this is a picture of a specific device that's used for hip traction. You can do it manually as well, and that's probably more common. For mechanical hip traction, there are recommendations for when you're doing it. And this picture is someone doing doing hip traction manually with a belt. So they've got it tied to a post or something. You could do it where you're the post. The therapist is doing the traction, and we will do mobilization in your manual therapy class. So that's kind of the usual thing. I've never actually seen mechanical hip traction prescribed in the clinic, just manual. So self and a positional spinal traction is actually really useful for a lot of people for just relieving pressure on their spine. If they get relief from unloading the spine, this might really help them. So you use your body weight to exert distractive forces of the spine. Really useful for lumbar, not as useful for cervical. Good when low forces are required. So one of them, the top picture there, the guy is just pushing up in a chair and his body weight gives him spinal traction. And like hanging in the corner of a kitchen counter, that's a nice way to unload your lumbar spine too. So there are a couple therapists that I've worked with who would go in the parallel bars and unload their lumbar spine. You can do that too if you have access to parallel bars. But that's a nice thing to teach a patient to do, just to unload their lumbar spine. You can also do positional traction side lying to unload specific facet joints, put a roll under one side and unload specific areas of the spine for positional traction. And we will do that in lab as well. So inversion traction, this is something that someone can do at home. These inversion traction units aren't very expensive. The last I heard, somebody told me it was about $200 at Costco when it's not on sale. So they're pretty easily found. The clinic where I've worked for the last 15 years, we had one of these, and it was nice um, to try it out with a person. And certain things really respond well to inversion traction. So it uses the patient's body weight basically to apply traction to a lumbar spine. And people that get relief from this love it. So they go, yeah, I'm going to go to Costco and buy one. Manual traction, you can use your hands. The therapist administers the force in the direction of distracting the joints. So you can do lumbar like the therapist is doing in the bottom picture, just with the knees bent and you're holding behind the knees. You can also do it with their legs up on a ball and you roll the ball towards you. You can do cervical traction supine or in sitting where you have your hands on either side of their head, like it's showing there. And it can actually be really relieving, manual traction. You're going to document the type of traction, mechanical or manual, area of body where it's applied, patient position, prone, supine, seated, etc. Whether their spine is in flexion or neutral or extension, the type of halter, maximum force used. With intermittent traction, you put hold relax time, and usually you put like on 15 seconds / off 15 seconds, or just say on off time 15/15, or however you're going to say it. And the force during the relaxed time. So sometimes it's let's just say 75 pounds. I'm just going to say that for a person that weighs 150 pounds. So you'd say 75, 0, 15, 15. 75/0, 15/15. So if you're not going all the way to 0, so 75, 10, 15, 15. So you let off some of the pressure, but not all of it. You could do that. How long you did it and how the patient responded. Makes sense, right?